Also wanted to point out here that aspirin is not to be used with children under the age of 12 because of the occurrence of Ray's syndrome, so avoid those. Then we get into our thrombolytic drugs, and on these they actually lyse those clots that have already formed. And I literally think about these as Pac-Man trying to eat clots as they've already occurred. With my thrombolytics, they're coagulation modifiers that lyse or actually eat the thrombus, especially in the coronary arteries, which supply the heart with blood. They reestablish that blood flow to the heart-starved heart muscle. If the blood flow is reestablished early enough, then the heart muscle and the left ventricular functioning can be saved. If not, then we have an MI. If blood flow is not reestablished early, the affected area of the heart becomes ischemic and eventually necrotic and non-functional. So think if that happens, then that necrotic is my myocardial infarction, and that non-functional is my heart failure. So that's why we want to lyse those clots as quickly as possible. On these, they impact the drug of choice for this. It's a tissue plasminogen activator. We lovingly call it TPA. It's a naturally occurring plasminogen that will actually eat or dissolve those coronary thrombus very quickly. The only problem with that is they're not specific to just coronary thrombi. So if there are other clots in the individual, they're going to lyse those also, so it can cause bleeding. So keep that in mind just a second. The indications for these is typically if I have an individual that's coming in, we think they're having a myocardial infarction, where I have to lyse a clot to get that blood flow, especially cardiac blood flow back to the heart, or if I think they have an arterial thrombosis, a DVT. We can use it if I have a shunt or a catheter that's occluded, or a pulmonary emboli, or an ischemic stroke. Not a bleeding stroke, but an ischemic stroke. These are going to be contraindicated in drug allergies, and then specifically to the preservative that's found in the plasminogen TPA. Some of the most adverse effects of this one are intracranial, internal, and superficial bleeding. Other problems can be hypersensitivity, or can cause hypotension, and more severely those cardiac dysrhythmias. There really isn't an antidote if we overdose this, which means I'm going to have to treat them supportively. So if we mention that there's adverse effects that go along with bleeding, then we would treat them symptomatically or supportively, usually with IV fluids to help decrease that. If an individual has had recent surgery and they come in to the ER and we think they're having a myocardial infarction, they're not a candidate for this because their recent surgery would have caused clots to form, hopefully, so they're not bleeding from their surgery site, and then they wouldn't be able to get this. I've seen this once in the ER when someone had their a tooth impaction, so they had a tooth pulled within like the last 3 or 4 days, and then they get presented with an MI, and they weren't able to have the medication because it would loosen that clot, which was a fairly large one, in their mouth, and they were afraid the patient would bleed out because of that. Let's see, my interactions. Most common effects of drug interactions is increased intracranial or increased bleeding, which we mentioned. And of the drug itself, alteplase or TPA alteplase can be re-administered immediately in the event of a reinfarction, which is a good thing. Has a very short half-life of about 5 minutes, and it's thought to open up that clogged artery very rapidly, but the action is short-lived. Therefore, we have to give it. We'll have to start that patient on IV heparin to prevent reocclusion of that affected blood vessel. So then go back up to the few paragraphs earlier when we talked about heparin. We'd have to start that patient on a heparin drip, and I'd have to monitor their APTT time to make sure that we're keeping their blood thin enough to not reclot. I do want to bring up this antifibrinolytic drugs. This is used in surgery to promote clot formation, literally to be used in the surgery suite itself. And there's 2 specific drugs here, and they do it by working on that cascade to innervate that cascade and make the cascade work so that we will have somebody have a clot. And again, you'll specifically see this at the surgical site to stop excessive bleeding because it's going to cause increased platelet aggregation and clot formation. We use this to prevent bleeding or treatment of excessive bleeding, usually from systemic fibrofibrinolysis from surgical complications. It's contraindicated with drug allergies to a specific thing that's within that specific product that's found within it. The adverse effects of this one is uncommonly, and they're usually very mild. However, there could be a rare occurrence where I could cause a patient to have a cerebrovascular thrombosis or an acute MI. Table 26.6 does a good job of showing us the adverse effects, and then there's some interactions with additive effects that can occur, which would result in increased coagulation. I have two drugs of choice here. Skip the first one. Amapronic acid, which is my first one. We use that to prevent or control that excessive bleeding, which we mentioned earlier. Or desmopressin, which is my next one. We utilize this one for a specific plasma factor decrease. If they don't have this specific factor in the cascade factor, we would give it to those individuals to stop bleeding. Another use for this, which we'll talk about in another chapter, is we can give desmopressin to help with primary nocturnal enuresis. So if an individual is wetting their bed way past childhood, we can use desmopressin to stop with that. Scrolling down to the end of the chapter, when we're looking at nursing assessment, we want to know if a patient's prone to bleeding, if they're prone to clotting, if we're trying to prevent a blood clot from occurring. So assess that individual beforehand. If they're taking anticoagulants, we want to watch for bleeding. We want them to check for bleeding also, so think about hematuria, melena, bleeding of the gums, oral bleeding, etc. When we're going to evaluate their clotting factors before we give these medications, and then as we're implementing them, think about some of the specific things we mentioned. If it's scroll down a little bit. We can start a patient on one particular medication in the hospital, like a heparin drip, and then move them from the heparin drip to the low molecular weight, the enoxaparin injection, and then we can send them home on warfarin. They each would have different types of blood values that we look for. So if I have them in the hospital and I've got the heparin drip and I'm watching for their PTT, if I send them home with warfarin, we're watching for their INR. And then review the antidotes for each of these. So if an antidote for enoxaparin, which is this one up here, my low molecular weight one, my antidote for that would be my protamine sulfate. Same thing with my heparin, that would be a protamine sulfate. And then my antidote for my warfarin is my vitamin K. So make sure you understand the labs that we're using to check their blood clotting, and then the antidotes for each of those. And then in our evaluation, not only are we evaluating what we just mentioned, but we're evaluating for any signs of clot formation and then bleeding. So make sure we're understanding both of those. And if they have bleeding, ascertain where it's from, and is that impacting their mental status? Would it be cranially? Is it impacting their blood pressure, causing them to be shocky? Would that be more systemic? So paying attention to those and getting a good history and physical on the individual is important.